So the introduction. As you know, we have numerous effective hormonal and neuronal mechanisms to maintain glucose homeostasis. That's why healthy adults fasting glucose is more than 4 usually, and we don't have symptoms until we have our glucose down to 2.8 or 3. In non-bariatric patients, most common causes of exogenous of hypoglycemia are exogenous insulin administration or insulinoma. For the diagnosis of hypoglycemia, we use the old Whipple's triad. When we know that there are symptoms caused by hypoglycemia, when we can detect low glucose, and then when there is a reverse or improvement of symptoms when we give them glucose. We can divide symptoms of hypoglycemia into categories. The neurogenic or autonomic symptoms are the effect of the counter-regulatory hormones when there is lack of glucose, like adrenaline or noradrenaline or many others. And usually symptoms are a lot, like for example shakiness, palpitations, and usually they precede the proper neuroglycopenic symptoms that they are the effect of the lack of glucose in the brain. And they could be light, like fatigue or weakness, reaching then the major neurologic symptoms. We define as severe episodes when there is an event requiring assistance. We are discussing here reactive hypoglycemia. This could be diagnosed with an OGTT, but we have to take in your mind that the 10% of normal people can have a glucose less than 2.8 after 2 hours during an OGTT. And it's thought to be a functional disorder arising from a mismatch between insulin secretion and glucose entry into the circulation after a meal, and is not due to a lesion to a pancreas. Also, if we have to remember that insulinoma has been described after bariatric surgery, but the main difference is usually the presentation of hypoglycemia is in a fasting state. We have to exclude all the causes of hypoglycemia. There are maybe more than those that I'm showing to you. We have two of them. There are endocrine disorders, there are other major medical conditions or genetic causes that usually they can precede the operation, of course. We have also to make a distinction between dumping and hypoglycemia. Early dumping is usually in the first hour after a meal. Usual symptoms are those ones: wheezing, flushing, nausea, vomiting, diarrhea, or abdominal pain. It's thought to be due to osmotic effect of the food, so fluid in the gut and sympathetic activation. What we are talking about here is what is also called late dumping. It's proper hypoglycemia, and there is a delay. It must happen after, let me say, 1 hour and a half, 3 hours after a meal. Talking about prevalence, I'm going to use this study as this is an important study from Sweden. Big numbers. They just used as diagnosis of hypoglycemia the hospitalization, so they took into account only the major episodes. And as you can see, only after gastric bypass, there is a risk of 0.2% compared to 0.04% of the general population. But of course, they took just the major episodes, so we don't know anything about less severe hypos. This is a summary of prevalence. So even taking into account the different definition of hypoglycemia, patient selection criteria, duration of the follow-up, severe episodes usually are less than 1%. If you use OGTT or a meal test, especially the OGTT could be a little bit physiological, you can have, of course, the increased prevalence. And then studies utilizing CGM suggested that hypoglycemia could be even more prevalent. In fact, if you look at this study, they found that in patients with after gastric bypass, patients they can spend up to 2.9% of their time in hypoglycemia without being aware. As you can see here, hypoglycemia at the top and the control there. The explanation for that, the same authors try to explain that, and so they created a situation of hypoglycemia, and they saw that patients after gastric bypass, they have a reduction of symptoms of awareness assessed by a scale, And they are also a marked reduction of the level of counter-regulatory hormones, like, for example, glucagon, cortisol, and catecholamines. So they cannot feel the hypoglycemia, so maybe hypoglycemia prevalence could be even higher than expected. Causes. As you know, there are many mechanisms involved in weight loss and diabetic resolution after surgery, and maybe many of those mechanisms could be also responsible for hypoglycemia. We know that extreme weight loss after bariatric surgery is possible, so is hypoglycemia the type 2 diabetes remission in the extreme? There are a lot of proposed mechanisms. As you can see here, this is located in all the GI tract, like, for example, accelerated gastric emptying or increased GLP-1 secretion, altered bile acid composition, gut flora, and so on. The final effect of all of them is to increase postprandial insulin secretion, and so to have postprandial hypoglycemia. When it was first described in 2005, initial reports suggested a role for increased beta cell mass, or so-called nesiodoblastosis. However, those findings were not universally supported. And GLP-1 has gained a major role as one of the main mechanisms of hypoglycemia post-bariatric surgery. This study, they compared patients after gastric bypass with symptoms of hypoglycemia with patients with no symptoms, and they found that patients with hypoglycemia, they have higher insulin and lower glucose. And those patients have markedly increased postprandial GLP-1 level, as you can see here, that is likely to contribute to the exaggerated insulin secretory response. Another interesting study is a case report, is this one. They had the lucky chance to study a patient after gastric bypass with the normal gastric bypass anatomy, and then inserting a tube for a gut obstruction in the stomach, so to study the normal anatomy. So this is a patient, 35 years old, 3 years after gastric bypass, with a good weight loss, with hypoglycemia episodes. And as you can see here, very low glucose, very high insulin, very high GLP-1, and very high GIP. When they gave her food through the tube in the stomach, there was a marked improvement of the, all these parameters, like the glucose is higher, insulin is lower, GLP-1 is corrected, and also GIP. So it's not a highlight issue, but it's the result of an altered nutrient delivery pattern. Again, just to stress the role of GLP-1, if you block GLP-1 receptor with exendin 9, as those out of state, you can see glucose was very low before, and insulin was very high. After the blockade of GLP-1 receptor, there is a normalization of these two parameters, and also a normalization of the symptoms, especially during the glucose fall phase, using a scale. How can we treat hypoglycemia? There are 3 levels. Diet is for everyone, usually is enough. In special cases, we can use medications. In selected cases, we can use surgery. Diet. There is this study saying that carb restrictions appears to be a good first-line approach. They used a 30-gram carbo-restricted meal, and that was able to prevent hypoglycemia in all their patients, so that's very good. But then, for example, there is this other study where they compared one day, the first day, with a high carbohydrate diet against, on the second day, a very extreme diet with very low carbohydrates, with the same amount of calories. And of course, as you can see, during the high carbohydrate diet, you have a high insulin level, and of course, you have low glucose. Everything was normalized during the extreme, very low carbohydrate diet. But then when they tried to use this diet for a month, they did not obtain a complete resolution of symptoms in all the patients, but just 25% of the patients with a complete resolution, with many patients with no improvement at all. So even a very intensive diet, with a very intensive diet, it's not possible to have benefits in all the patients. That's why this is a list of modifications to the diet that we use in our clinic. We ask patients to avoid sugary food and drinks, to avoid long periods without food, to include some lower GI food at every meal, of course with 30 grams every meal, adequate protein, avoid fluid with meal to slow stomach emptying, avoid gastric irritants, take time when eating, and regular healthy snacks. Medications. There is a list of medications that are commonly used for hypoglycemia. Acarbose is a medication that interferes with the carbohydrate absorption in the small intestine. Diazoxide interferes with the insulin release, acting on potassium channels. Octreotide, the injections can delay gastric emptying and transit through the small intestine, and inhibits the release of many gastrointestinal hormones with, of course, many side effects. Calcium channel blockers can interfere with insulin release through the action of calcium channels. Many of them, they can be used also in combination. Then there is liraglutide. It seems like a paradox, using GLP-1 agonists to correct the effect of high GLP-1 secretion. But then, according to this study, there is just one study, they were able to solve 6 cases of untreatable hypoglycemia with liraglutide. Maybe liraglutide has different characteristics because it's a long-acting receptor agonist. So according to those authors, it's possible to downregulate insulin secretion, to upregulate glucagon level, and to slow gastric emptying to solve hypoglycemia. Talking about Xendin-9 again, this is a very recent study. They used Xendin-9 in a single subcut injection, and that was able to completely prevent hypoglycemia. So this could be a new promising treatment, hopefully. Surgery, I'm not a surgeon, but as you saw before, a gastrostomy tube, a gastrostomy feeding could be a kind of a test to see, because if there is a normalization with a gastrostomy tube, patients are likely to benefit from gastric bypass reversal. Talking about gastric bypass reversal, I found a review. So as you can see here, after reversal, 76% of the patients had the resolution of symptoms, not all the patients. The problem is weight regain, of course. If you consider partial pancreatectomy, another review, not all the patients that can have complete resolution of symptoms. The problem here is the terrible diabetes that you can obtain after that. There are many other procedures. You are more expert than me. The aim of all these new procedures is to improve symptoms and try to avoid the weight regain. So they could be really helpful and appreciated. Finally, there are no agreed optimum diagnostic and therapeutic strategies for hypoglycemia post-bariatric surgery. The causes are still unknown. We have many mechanisms, but we are not sure. And study these patients may hold the key to understanding the effect of bariatric surgery. And I want to say thank you to all my team.